Welcome to Pulse and Pressors, where critical care gets crystal clear. Systemic vascular resistance is calculated as MAP minus CVP divided by CO times 80. The 80 is not arbitrary. It converts the units from millimeters of mercury per liter per minute into dynes per second per centimeter to the power of -5, which is the standard hemodynamic unit. If you omit the 80, you are working in Wood units. SVR equals MAP minus CVP divided by cardiac output, with normal values around 10 to 15 Wood units. Multiplying by 80 translates those units to the familiar 800 to 1200 dynes per second per centimeter to the -5th power range. This formula highlights that SVR is fundamentally about tone and flow together. Shock is defined by how SVR and cardiac output relate, not by MAP alone. Normal SVR ranges from 800 to 1200 dynes per second per square centimeter, with SVRi typically 1970 to 2390 dynes per second per square centimeter per square meter. In distributive shock states such as sepsis or anaphylaxis, SVR often falls below 800, with severe vasoplegia below 600 and critical vasoplegia below 400. In cardiogenic or hypovolemic shock, SVR rises above 1200, with severe constriction beyond 1500 and potentially above 2000. Mixed or terminal shock appears when cardiac index is low and SVR is also low, signaling catecholamine exhaustion and end-stage physiology. High-output shock is characterized by a cardiac index above 3.5 to 4.0 liters per minute per square meter, combined with SVR below 800, the classic distributive pattern. Poiseuille's law explains why SVR is so sensitive to arteriolar radius. Resistance is inversely proportional to the fourth power of the radius. This means a small decrease in arteriolar diameter causes a dramatic increase in SVR, and a small increase in diameter sharply reduces SVR. Arterioles are the major resistance vessels. Their tone determines LV afterload and strongly affects stroke volume and cardiac output. At the macro level, MAP equals cardiac output times SVR. But Poiseuille explains why a small change in tone can completely transform that relationship. In shock states, SVR is a primary classifier. Low SVR is the hallmark of distributive shock, seen in sepsis, anaphylaxis, and neurogenic shock. High SVR characterizes hypovolemic and many cardiogenic states as the body clamps down to preserve perfusion pressure. When SVR is normal but cardiac output is low, the primary problem is pump failure rather than tone. High-output shock arises when cardiac index is elevated, but SVR is profoundly low. Here, resistance is the dominant abnormality despite vigorous flow. The SVR plus cardiac output matrix provides an immediate visual framework for classifying shock. High cardiac output with low SVR indicates distributive or vasoplegic shock. Low CO with high SVR defines cardiogenic or hypovolemic shock. Low CO with low SVR signals mixed or late-stage shock. High CO with high SVR may represent early compensated states or overpressing with vasoconstrictors. This quadrant model makes it obvious that MAP alone cannot distinguish these patterns. You need both SVR and CO. Bedside cases anchor the numbers in reality. In early septic shock, a MAP of 70 with a cardiac output of 8.5 liters per minute and CVP of 8 millimeters of mercury yields an SVR of about 583 dynes per second per centimeter to the power of -5, revealing severe vasoplegia despite an acceptable MAP. In cardiogenic shock with a MAP of 65, CVP 18, and CO 3.2 liters per minute, SVR is around 1175, showing a compensatory vasoconstriction response. The fix is inotropy and afterload management, not simply more pressor. In mixed shock, a low MAP with low cardiac output but only modestly elevated SVR exposes a combination of pump failure and vasoplegia, justifying both vasopressors and inotropes. After cardiac surgery, a patient on norepinephrine may have a MAP of 75, cardiac output 6.5, and CVP 10. The SVR of about 800 shows borderline vasoplegia despite decent numbers, pointing you toward adding vasopressin or targeting tone, rather than chasing MAP alone. SVR often reveals truth when MAP is deceptive. Early in sepsis, SVR may collapse while MAP remains normal because the heart is compensating with a high cardiac output. In later cardiogenic shock, MAP falls while SVR becomes extremely high as the vascular system attempts to salvage perfusion. Vasoplegia post-surgery or in septic patients can manifest as high cardiac index with low SVR. They remain in shock despite apparently strong flow. Mechanical support devices may normalize MAP, while SVR still reflects the underlying pathology, making SVR critical for understanding why pressure changed and what remains unfixed. SVR responds to multiple physiologic levers. Vasodilation from sepsis, anaphylaxis, or spinal cord injury sharply reduces SVR. Vasoconstriction from hypovolemia, catecholamines, pain, and cold drives SVR upward. Hypothermia induces intense vasoconstriction. Hyperthermia relaxes vessels. Severe acidosis blunts vasopressor efficacy, limiting how much SVR can be increased. Endothelial dysfunction alters both baseline tone and the response to vasoactive agents. Interpreting SVR correctly requires considering these background influences. Different vasoactive agents shift SVR in characteristic ways. Norepinephrine typically raises SVR by about 20 to 40%, primarily via alpha-1 mediated vasoconstriction. Vasopressin adds 15 to 30% of non-adrenergic vasoconstriction and is catecholamine sparing. Phenylephrine, a pure alpha-1 agonist, can raise SVR by 30 to 50%, but risks reducing cardiac output via reflex bradycardia. Epinephrine's effect depends on dose, with low-dose beta activity sometimes reducing SVR and high-dose alpha activity increasing it. Inodilators like dobutamine and milrinone reduce SVR by 10 to 25 and 20 to 40% respectively, improving forward flow but risking hypotension. Nitroprusside and nicardipine strongly reduce SVR, which may be therapeutic in afterload-heavy cardiogenic states. Global SVR is not the same as organ perfusion. Organ perfusion pressure is MAP minus organ venous pressure, but actual flow depends on local vascular resistance. High SVR can maintain MAP while reducing cardiac output and shunting blood away from non-autoregulated organs like the gut and skin, risking ischemia. Auto-regulated organs such as the brain, heart, and kidneys maintain flow across a range of pressures, but fail when extreme SVR or MAP changes exceed their limits. The practical goal is not the highest SVR with a good MAP, but adequate MAP at the lowest necessary SVR to ensure both pressure and flow. Different ICU disease states have characteristic SVR patterns. In septic shock, early SVR values are often 400 to 700, falling below 400 in refractory vasoplegia. Cardiogenic shock may initially feature SVR of 1,200 to 1,800 as compensation, rising above 1,800 to 2,000 in decompensated states where afterload further strangles cardiac output. Anaphylaxis acutely drops SVR below 600. Neurogenic shock decreases SVR via loss of sympathetic tone and is often associated with bradycardia. Post-bypass vasoplegia presents with surprisingly low SVR, despite adequate volume. Cirrhosis produces chronic low SVR with hyperdynamic circulation. Hypothermia can raise SVR above 1,500, creating deceptively reassuring MAP with low cardiac output. SVR pitfalls largely stem from inputs. Errors in cardiac output, MAP, or CVP propagate into SVR. High CVP increases the numerator and can falsely elevate SVR. Severe tricuspid regurgitation, or shunts, distort CO measurement, making SVR appear misleadingly low or unstable. Early sepsis can show very high cardiac output and apparently moderate SVR, that is actually dangerously low for the patient's physiology. Positive pressure ventilation changes both MAP and venous return, altering the interaction between cardiac output and SVR. Always cross-check SVR against the clinical picture and method integrity. The reliability of SVR is only as good as your cardiac output measurement. Thermodilution via PA catheter is the classic standard, but is affected by tricuspid regurgitation and intracardiac shunts. Pulse contour methods assume reasonably stable resistance during rapid SVR shifts. Their cardiac output estimates may be inaccurate and thus distort SVR. Echocardiographic cardiac output using LVO-TVTI is physiologically solid but intermittent and operator dependent. The FIC method is highly accurate but impractical for continuous monitoring. Sudden swings in calculated SVR often reflect measurement noise or method limitations. Trends, context, and waveforms are crucial. Indexing SVR to body surface area SVR. I better normalizes comparisons across patient sizes. In large or obese patients, a normal SVR may hide clinically important vasodilation. In small patients, a modestly elevated SVR may not reflect extreme vasoconstriction. SVRi values between roughly 1970 and 2390 dynes per second per cubic centimeter to the negative fifth power per square meter are typical. For shock classification and research level analysis, SVRi is often more informative than SVR alone. Arterial elastance is an advanced metric that describes the pulsatile component of afterload and LV arterial coupling. While SVR captures steady-state resistance, arterial elastance is estimated as approximately 0.9 times SBP divided by stroke volume. A normal arterial elastance, around 2.0 to 2.5 millimeters of mercury per milliliter, reflects efficient coupling. It is possible to have a normal SVR, but a high arterial elastance in stiff arterial systems, such as those seen with aging or chronic hypertension, increasing LV workload despite normal global resistance. This concept becomes important in advanced heart failure and ventriculoarterial coupling assessments. In device-supported patients, SVR interpretation becomes more complex. Impella unloads the LV, reducing wall stress and altering the relationship between MAP and cardiac output. An intra-aortic balloon pump augments diastolic pressure, which changes mean arterial pressure and therefore apparent SVR. VA ECMO adds parallel flow, making MAP a function of both circuit flow and native cardiac output. Because these devices change flow and pressure relationships, SVR must be trended and interpreted alongside device settings and native hemodynamics. SVR targets vary by shock type. In septic shock, your goal is to raise SVR from critically low values toward the normal range of 800 to 1200, but not to overshoot into excessive vasoconstriction that impairs microcirculation. In cardiogenic shock, an SVR above 1500 to 1800 adds afterload and worsens CO, carefully reducing SVR to around 800 to 1000 while supporting contractility can improve forward flow. After cardiac arrest, an SVR of 800 to 1200 is generally desirable, avoiding extreme vasoconstriction that would impair organ recovery. There is no universal magic number for SVR. It must be tailored to the shock mechanism. SVR has important limitations. It is a derived global average that cannot capture regional heterogeneity or microvascular dysfunction. In sepsis, for example, some vascular beds may be profoundly dilated, while others are constricted, yet SVR reports only a single average number. Normal SVR does not guarantee normal tissue perfusion if microcirculatory shunting, capillary leak, or endothelial dysfunction are present. For this reason, SVR must be complemented with lactate, SCVO2, capillary refill, skin findings, and, when available, regional perfusion tools like NIRS. The modern view of hemodynamics is that SVR, interpreted alongside cardiac output, defines the shock mechanism far more accurately than MAP alone. MAP is the visible tip of the iceberg. SVR and cardiac output are the structure underneath. Deciding whether to give fluid, add vasopressor, reduce afterload, or increase inotropy requires understanding both resistance and flow. SVR, used intelligently, is a core part of this reasoning. The expert takeaway is that SVR explains shock better than pressure ever will. Normal MAP with critically low SVR is still severe shock. Conversely, elevated MAP attained only by extreme vasoconstriction can coexist with low-flow organ ischemia. Your goal in resuscitation is not simply a MAP above 65, but adequate organ perfusion with the lowest necessary SVR and sufficient cardiac output. SVR, when combined with cardiac output, lactate, and clinical assessment, becomes a powerful tool for precision resuscitation. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.